Hello dear friends, how are you doing today? I hope you are doing well. Welcome to a new question about dermatology. A 34-year-old man presents to the dermatology clinic with an itchy rash on his palms. He has also noticed the rash around the site of a recent scar on his forearm. Examination reveals papules with a white lace pattern on the surface. Some isolated white streaks are also noted on the mucous membranes of the mouth. What is the diagnosis? A. Lichen planus. B. Scabies. C. Lichen sclerosus. D. Morphea. And E. Pityriasis rosea. The diagnosis here is Lichen planus, and we are going to explain why the diagnosis is Lichen planus. Lichen planus definition. Lichen planus is an idiopathic inflammatory disorder of the skin. Clinically, the papules are flat or planus and are surmounted by subtle fine white dots and lines that with imagination resemble the appearance of lichen found in nature. Flat-topped or planar purple papules with Wickham's styria in a patient with lichen planus. This white lace pattern is called Wickham's styria. Flat-topped planar or purple papules with Wickham's styria in a patient with lichen planus. Lichen planus is characterized by the 5 P's: purplish, planar, pruritus, polygonal, and papule. As we can see here, we can see purplish, planar, and polygonal papule, which usually are pruritic. Incidence: the disorder is uncommon but not rare. It is estimated that lichen planus affects less than 1% of the population. Lichen planus can occur in both children and adults. History: the major complaint is itching, which is often severe. Mucous membrane involvement sometimes results in painful erosions. Lichen planus-like eruptions can be induced by drugs, so a careful drug history should be elicited. Clinicians should have a high index of suspicion regarding lichen planus in patients with hepatitis C virus, although the cause and effect relationship remains uncertain. Physical examination: the primary lesion is a purple polygonal flat-top papule. Its surface has a fine reticulate pattern of white dots and lines, which is called Wickham's styria, as we said, that can be visualized on close inspection. Wickham's styria are more readily visible through a handheld lens after the application of a drop of oil on the surface of the papule. The papules are sometimes arranged in streaks, presumably resulting from the trauma of scratching or is called Koebner phenomenon. Here we can see papules in streaks or Koebner phenomenon in patients with lichen planus. The wrists and ankles are favored locations for lichen planus, but any area may be affected, including the palms, soles, and genitalia. Palmar plaque with characteristic papule involving the flexor wrist in a patient with lichen planus. The nails and hair follicles are occasionally involved with dystrophic change and even scarring. In lichen planus, nail matrix involvement leads to dystrophic nail, as we can see the dystrophy of the nails in a patient with lichen planus. Mucous membrane involvement is more common, and in some patients it is the sole manifestation of the disease. Most often this condition appears as white streaks in a reticulate pattern. As we can see here, we can see reticulate lace-like pattern of lines and papules on the buccal mucosa in a patients with lichen planus. Blisters and erosions also sometimes occur. The buccal mucosa is affected most often, but the tongue, lips, and gums may also be involved. As we can see here, we can see the involvement of gums in a patient with lichen planus. Also, we can see the involvement of buccal mucosa. Oral lichen planus ulcers on the tongue requires a biopsy to exclude malignancy, and it's a very important point in patient with involvement of the tongue with lichen planus. Differential diagnosis: The white lines on the surface of violet lichen planus papules are often subtle, so the disease usually does not appear as a scaling disorder. Occasionally, however, most scales can be present, in which case the papulosquamous disorders must be considered, including psoriasis, pityriasis rosea, and discoid lupus erythematosus. Of this, discoid lupus is the most commonly confused, and in some patients, the two diseases may overlap. Lichenoid drug eruptions can mimic lichen planus. Drugs that most often cause lichenoid eruptions are angiotensin converting enzyme inhibitors, beta blockers, thiazide diuretics, antimalarials, quinidine, and gold salts. The lesions are generalized, often in photodistribution and more eczematous, leading to persistent sign of hyperpigmentation. Lichenoid drug eruption generalized distribution with psoriasis like eczematous papules and plaques. Here you can see also the lichenoid drug eruptions. Lichen nitidus and lichen spinulosus do not have the purplish flat-topped appearance of lichen planus. When the path and soles are involved, a serologic test for syphilis should be performed to rule out secondary syphilis. Some patients with graft versus host disease also develop a skin eruption that closely resembles lichen planus, both clinically and histopathologically. Here we can see lichen nitidus, fine, flat-topped, shiny papules, and lichen spinulosus, a follicular variant of lichen nitidus. Groups of small shiny papules is visible. The differential diagnosis for mucous membrane involvement with lichen planus include leukoplakia, candidiasis, and secondary syphilis. As we said, the biopsy is important in the involvement of the tongue with lichen planus to exclude their malignancy. The conclusion of differential diagnosis of lichen planus include papulosquamous disorders like psoriasis, pityriasis rosea, discoid lupus erythematosus, lichenoid drug eruption, lichen nitidus, and lichen spinulosus, secondary syphilis, and graft versus host disease. And the conclusion of drugs that can cause lichen planus like eruptions include thiazide diuretics, AC inhibitors, beta blockers, gold salts, antimalarial drugs like chloroquine, hydroxychloroquine, and quinidine. Laboratory and biopsy. If the clinical diagnosis is in doubt, a biopsy may be performed to confirm the diagnosis. In lichen planus, the histologic features are characteristic. The typical constellation of findings includes hyperkeratosis, thickened granular layer, degeneration of the basal cell layer, colloid bodies or necrotic basal cell, and a dense or band-like inflammatory infiltrate in the papillary dermis that obscures and disrupts the dermal-epidermal junction. As we can see here in lichen planus, in epidermis, we can see hyperkeratosis, degeneration of the basal cell layer, which presents as a sawtooth pattern of red packs, and in dermis, we can see the dense band-like lymphocytic infiltrate in their upper dermis. Here we can see the thickened stratum corneum and thickened granular layer or stratum granulosum is thickened in patient with lichen planus, and we can see the sawtoothing of dermoepidermal interface or dermoepidermal junction, and is pathognomic in lichen planus. Here we can see also the thickened or stratum corneum. We can see the thickened or granular layer. Also, we can see their lymphocytic infiltrate in their upper dermis. Therapy. The treatment is non-specific and often not totally successful. The inflammatory reaction is suppressed with steroids. Localized disease is treated with strong topical steroids such as fluocinamide 0.05% cream, especially in children. For severe widespread disease, a course of systemic steroids is sometimes required, but caution is advised when administering these agents on a long-term basis because of the well-known side effects. Acetretin or seriatin 25 to 50 mg daily can be effective in clearing cutaneous and oral lichen planus in more severe cases. Topical retinoids or tretinoin gel and topical steroids or clobetasol gel have been successful in some patients with mucous membrane lesions. Topical tacrolimus has also been used effectively for oral and cutaneous lichen planus. Phototherapy with narrowband UVB can be beneficial for generalized lichen planus and lichenoid drug eruptions. Cyclosporine has been used as a treatment of last resort in selected patients with severe disease. Therapy for lichen planus, the initial therapy is topical steroid or with fluocinamide cream 0.1%. Alternative therapy include topical tacrolimus, systemic steroids, narrowband UVB, retinoids like acitretin and cyclosporine. The course may be chronic, ranging from months to years. Almost 2/3 of patients experience spontaneous resolution within 1 year. Patients with mucous membrane involvement usually have a more prolonged course, often lasting years. Recurrences are uncommon, occurring in less than 20% of patients. Serious complications are uncommon. Post-inflammatory hyperpigmentation may be cosmetically unpleasing and can be treated with skin lightening therapies, but usually fades with time. Complications of mucous membrane lichen planus include candidiasis and squamous cell carcinoma, necessitating routine clinical follow-up and biopsy of changing oral lesions. Pathogenesis. The cause of lichen planus remains unknown. Evidence that immune factors play a role includes the finding of immunoglobulins at the dermal-epidermal junction in 95% of lichen planus lesions. The observation that certain drugs reactions can mimic lichen planus and the occurrence of lichen planus-like eruptions in patients who have undergone bone marrow transplantation and who are experiencing a graft versus host reaction. Okay, this was a short explanation about lichen planus presentation and management.